I will discuss with you about the updates on the trigeminal neuralgia. I have nothing to disclose. This is an overview of the presentation. Before I start my formal presentation, I would like to show you something different. The invisible hell, trigeminal neuralgia, a patient's perspective. These are the drawings created by the people living with the trigeminal neuralgia, a visual expression of what they experience daily, their pain and their agony. This is a poem written by one of the patients. Being the clinicians and being the neurologists, we heavily depend upon our diagnostic tools for the diagnosis of any disease. However, the pain is something which is very subjective and it's usually very difficult to quantify it, especially in the case of neuralgias like that of the trigeminal neuralgia. They say laughter is the best medicine unless it feels like a lightning bolt to the face. Imagine being afraid to smile. How painful it would be. New York Post on April 22, 2025 labeled this as an incurable suicidal disease and it can be triggered by the smiling. Coming towards my formal presentation, trigeminal neuralgia is a condition that is characterized by the recurrent brief episodes of the unilateral acute shock-like pains that are abrupt in onset and termination, occurring within the distribution of one or more deviants of the fifth cranial nerve and are typically triggered by the innocuous stimuli. Now, what are the innocuous stimuli? These are usually harmless and not painful stimuli, like that of the smiling, eating, chewing, brushing, or that of the shaving. As far as the epidemiology is concerned, it is a most well-known and often most severe facial neuralgia with the lifetime prevalence is higher in women and estimated to be between 0.16 to 0.3%. The annual incidence is 4 to 13 per 100,000 and in Pakistani studies it's about 12. Despite its low prevalence, it affects the females more frequently than the males and with the female to male prevalence ranging from the 1.5 to 1 to 1.7 to 1. Coming towards the clinical diagnosis. The diagnosis is made in the patients with the compatible clinical features and the International Classification of Headache Disorder, 3rd edition, the criteria are as follows. The International Classification of Headache Disorder has undergone a significant evolution since its formation in order to improve the sensitivity and the specificity for the diagnosis of different headache disorders and also the neuralgias like that of the trigeminal neuralgia. In ICHD-1, that was in 1988, it was just broadly classified. Then in the ICHD-2, the two terms, that is the symptomatic and the classical, were introduced. Whereas in the ICHD-3, it was further divided into 3 types with inclusion of the subtypes depending upon the pain pattern. It means that initially there was just the paroxysmal pain was defined. However, now they have, now not in the 2018, they added the presence of the continuous pain in the patients with that of the trigeminal neuralgia. Now, what are the diagnostic features? These are the recurrent paroxysms of the unilateral facial pain in the distribution of one or more deviants of the trigeminal nerve with no radiation beyond and fulfilling the criteria. The pain has following characteristics from the fraction of second 2 minutes, severe intensity, then shooting, stabbing, or sharp in quality, precipitated by the innocuous stimuli as well as no better countered by another ICHD-3 diagnosis. These are the 3 subtypes I was talking about. Idiopathic, as the name is telling, no cause is identified and it presents about 20% of the cases. Classical refers to the symptoms due to the neurovascular compression, not simply contact, with the morphological changes in the trigeminal nerve node and is present in about 75% of the cases. This is very important. Remember that the neurovascular bundles, they may be present even in the asymptomatic patients, but we have to see whether they are significant or not, whether they are resulting in the morphological changes or not. Then we have the secondary, which could be because of the MS, CP angle tumors and the AVMs, and it's present in about 15% of the cases. Pathophysiology, it is one of the facial the headache disorder with a very complex pathophysiology as well as etiology. That's why in spite of the availability of multiple therapeutic options, the clinical outcome in a subset of patients always remains suboptimal in the patients of the trigeminal neuralgia, which is one or another way related to its complex pathophysiology. Traditionally speaking, it was explained by the means of the mechanical insults, resulting in the peripheral neuronal hyperexcitability or ignition phenomena. Ignition phenomena is basically the base of it, that whenever neurovascular bundle is come in contact, there is a focal demyelination, resulting in the formation of very hyperexcitable area at the root entry zone. That is the site where the trigeminal nerve enters into the brainstem. However, with the passage of time, the scientists, they realized that it's not just a peripheral phenomena, whereas there is also the CNS involvement. This is a very important concept because it will answer many questions. Central maladaptation, neuroplasticity, or central sensitization. Basically, it is a heightened response of the brain to that of the heightened perception of the pain, to that of the normal innocuous type of the stimuli, with structural and the functional changes within the brain in response to these stimuli. This is basically the neuroplasticity. It answers three questions here. One is that because of this phenomena, the continuous pain pattern was added along with that of the paroxysmal pain in 2018 criteria. Second, is this one of the bases of failure of the microvascular decompression surgery in the patients with that of the classical trigeminal neuralgia? And third is that it forms the basis for the use of the neuromodulation as one of the treatment strategy in the case of trigeminal neuralgia. I think this was the question that was asked yesterday about the role of DBS and that of the peripheral neuropathy, and is one another way related to this phenomena. Now I have highlighted the three pathogenic phenomena. These are the nowadays latest areas of the interest. One is the relationship between the trigeminal neuralgia, inflammatory and oxidative stress pathways. As scientists have found that there are elevated levels of the reactive oxygen species or the interleukins or cytokines within the CSF of the patient having the trigeminal neuralgia. While making this presentation, I found many very interesting studies about the role of trazodone. Trazodone is basically a serotonin antagonist that we use it during for the depression or insomnia, as its role in the inflammatory and oxidative stress pathway in the neuropathies, including that of the trigeminal neuralgia. However, more of these studies were in the animal models. Then genetic predisposition, especially, and that subgroup is not responding to our treatment. Because of the suspected mutations within that of the sodium voltage channels. And last is emerging system influences, for example, gut microbes, because it is always thought that there is excess of the gut with that of the brain. This is a diagrammatic representation of these complex mechanisms. These are the papers from where I have taken all these pathophysiology. JCPSP on April 25, 2025, published a paper about the genetic association between the hypothyroidism and the risk of trigeminal neuralgia. Now coming towards the diagnosis, a currently used MRI technique for trigeminal neuralgia involves using high-resolution three-dimensional sequences, that is the Fiesta, CIST, and the TOF MRIs, to detect the neurovascular compression. These three are currently available here and we are using them. Now what's new? Macromolecular proton traction, MPF-MECM, as a myelin biomarker. Basically, it works like that of the myelin detector or a myelin sensor. In February 2025, a study published in the American Journal of Neuroradiology, it investigated the MPF mapping, a quantitative MRI technique sensitive to the myelin, as a novel imaging biomarker in patients with primary trigeminal neuralgia. So it's a very new technique. What they did, they compared the 56 patients of the primary trigeminal neuralgia with 27 healthy controls, and they found that there was a decrease in the MPF indicative of the demyelination in the patients. So this is a very latest technique. What else? We have different tensor imagings and the tractography. These are recently introduced functional MRI technique used for the depiction of microstructural white matter changes of the brain and the trigeminal nerve. DTI basically works same like that of the diffusion weighted images in the case of stroke by using the diffusion of the water molecules. And the tractography, then it used this data to reconstruct the 3D models of the neural tracts allowing the visualization of nerve pathways. I'll just show you these now. Then use of the AI applications. Now this is a DTI image. As you can see, there is a compression on the left side as shown by the red arrow. Then there are two colorful DTI images, and then there is a tractography. I will not go into the details how to interpret them, but just to make the thing simple, basically DTI is a quantitative type of the data. Like we have the values. We have baseline values, and then we compare the values of the both sides. One is the values that is known as the anisotropy, that how smoothly the current is flowing. And the second is the diffusibility. When we compare them on both the sides, there will be definitely a difference between the normal and abnormal size. And depending upon this data, then the tractography is done and the tracts are drawn. Another image that is showing compression on the right side with decreased values on the right side and beautifully drawn tracts. Tractography can be normal even in the presence of abnormal DTI images when the changes are subtle or they are very mild. These are the papers from where I have taken, these are radiology papers from where I have taken the reference. Now coming towards the pharmacotherapy, which is our area of the interest, pharmacological treatment based on the current evidence is strongly recommend the use of carbamazepine or oxcarbazepine as the first-line treatment, with the addition of the lamotrigine, gabapentin, botulinum toxin type A, pregabalin, baclofen, and the phenytoin as the mono or the add-on therapies when the carbamazepine and oxcarbazepine it proved unsuccessful. So these are the recognized facts. These drugs are given in the tableted form. I will not go into the detail. Now, what's new? Sodium channel blocker, Vixotrigine. It was an exciting milestone as it was the first time a drug had been tested exclusively for the trigeminal neuralgia. A phase 2A randomized withdrawal study showed encouraging results, though the sample size was small and the findings were not statistically significant. However, Biogen, the company behind it, withdrew its phase 3 trials in 2023, and as per May 2025 update, they have decided not to proceed with that of the phase 3 studies. This was the official statement given by that of the company. Now, another hope. This is a bisimgluran. It is basically a potent inhibitor of the metabotropic glutamate receptor 5, which controls a wide range of the processes in both the central and the peripheral nervous system. And it has shown the therapeutic potential for pain associated with the conditions such as that of the trigeminal neuralgia. It is developed by the Norma Pharma as a part of Libra study, and this current medication is currently tested internationally. Official registry says it began in 2022, will be completed by December 2025, and full completion by February 2027. So this drug is in the pipeline. Let's see what happens with it. Now, lacosamide. This is the drug which is available here. It's in the IV form and can be used in both the oral as well as an IV. Lacosamide is an anti-epileptic drug that has been studied and occasionally used off-label for the trigeminal neuralgia, particularly in the patients who are refractory to the first-line treatment. This was a very interesting comparison. A retrospective comparison of 3 drugs, lacosamide, gabapentin, and baclofen, published in 2025. It indicates that the lacosamide may be effective and the well-tolerated alternative to the gabapentin baclofen for managing the refractory trigeminal neuralgia. A total of 49 patients were included with 22 lacosamide, 13 gabapentin, and 14 with the baclofen. And the pain relief rate was 68% for lacosamide, 54% for gabapentin, and 64% for the baclofen. It's showing the efficacy of lacosamide that we can use it in the oral form as well as in that of an IV. This is the paper where I have taken. Aceclidine acetate, another drug which is available in Pakistan. It shows promising efficacy and tolerability in the observational studies, especially in the patients intolerant to the carbamazepine or oxcarbazepine. However, there is a limited to small-scale uncontrolled studies, and no randomized controlled trials have validated its use yet. Phosphanetine. Most of us have an experience of using the phenytoin during an acute exacerbation of trigeminal neuralgia. The IFT study evaluated the intravenous phenytoin for acute TN flare-ups, and the key findings were presented at the AN 2025. Interestingly, at 120 minutes after dosing, patient receiving phosphanetine had significantly greater pain relief compared to the placebo, with 90.9% achieved 50% reduction in pain versus 40% in placebo. And the pain frequency also dropped significantly within the 24 hours. So it means that the use of the phenytoin in our setup where the phosphanetine is not available is still clinically relevant. This is the paper. Then oral non-opioid analgesics, suzetrigine. It is a highly selective 1.8 sodium channel blocker. It earned its FDA approval in 2025. Though not yet studied specifically for the TN, but its novel mechanism targeting the peripheral sodium channel positions it as a potential candidate for that of the future trials. Professor Bashir Sumra was saying that it's available in Pakistan. It's FDA approved in Jan 2025. Then CGRP monoclonal antibodies, like that of the arenumab and the gluconazumab. These are being actively explored for the TN, but clinical efficacy data is not yet publicly available, though preclinical findings provide a rationale for this line of investigation. CGRP, then botulinum toxin. The 2019 European guideline recommended it as a second line or the additive option and not as a standard first line therapy. And the clinical trials strongly suggest that it is both efficacious and well tolerated for TN, especially in the refractory cases. However, due to the variation in dosage, injection technique, and limited sample size, larger and the more standardized RCTs are needed. This is a reference paper, magnesium. Nowadays, there is a growing hype about that of magnesium in almost all of the diseases. though it has been proved within that of the migraine. However, I was unable to find any large randomized control trial in the case of the trigeminal neuralgia. However, but there were many small-scale studies or the preclinical data were there. But a retrospective analysis presented at the American Headache Society in June 2025, that is few months back, it showed a promising effect of the intravenous magnesium and methocarbamol for an acute pain crisis in refractory trigeminal neuralgia. Methocarbamol is basically a muscle relaxant. It is a GABA receptor agonist and is available in oral form in Pakistan. So the results are very promising. It has shown about 89% reduction in that of the pain. So this is still unpublished data. Hopefully it will get published after the few months or years, and then let's see what happens with that of the magnesium. Now, a few slides about that of the latest advances in surgical, as it's already known that these are generally reserved for the patients who are having the debilitating pain and refractory to the pharmacological treatment. It could be invasive, non-ablative, that is a microvascular decompression, which is still the treatment of choice for the patients with the classical trigeminal neuralgia. And they could be invasive ablative in the form of mechanical, thermal, and the chemical means. Non-invasive ablative, that is a stereotactic radiosurgery, which includes both the gamma knife as well as the cyber knife, and the focus radiations at the trigeminal root entry zone. And if we talk about it in Pakistan, JPMC, I have talked to my friend, they are doing it free of cost in the patients with that of the trigeminal neuralgia. This is a diagrammatic representation of microvascular decompression, where a Teflon patch is placed between the superior cerebellar artery and that of the trigeminal nerve. This is the MRI and per-operative pictures. Balloon compression in trigeminal neuralgia. What's new? Awake microvascular decompression. The patient is kept awake by using the awake anesthesia protocol. However, this is reserved for the patient who are not the candidate for that of the conventional microvascular decompression. Then fully endoscopic microvascular decompression, that is done through that of the endoscope. Neuro-1 RF trigeminal nerve ablation system, it received the FDA clearance on August 18, 2025 for targeted radiofrequency minimally invasive surgery. And the Neuro-1 is a company behind it. It's planning a limited commercial launch of this system in late 2025. This is an endoscopic picture showing the superior cerebellar artery, ICA, as well as the fifth cranial nerve. Then few non-invasive, like that of the neuromodulation devices. External trigeminal nerve stimulation, then implanted systems in the form of subcutaneous trigeminal nerve field stimulation, peripheral nerve stimulation, sphenopalatine ganglion stimulation, and that of the DBS. This is a LIPUS machine. This is another non-invasive therapy, low-intensity pulse ultrasound. It works in the same way as that of the TENS, and it's emerging therapy for that of the trigeminal neuralgia. These are the papers from where I have taken the... I started my presentation by showing you the pain and the agony of the patient suffering from the trigeminal neuralgia. However, I would like to end it with a hopeful message. Trigeminal neuralgia, the suicidal disease, but let us redefine that name. Through knowledge, early care, and empathy, we can turn the despair into dignity and the pain into the progress. 7th October is celebrated as the International Trigeminal Neuralgia Day. These are my references. Thank you very much.